And so today we will continue discussing about retina. So we are done with these topics last week. So I divided the topic today into two: the pediatric retinal diseases, and the second part will be the common adult retinal diseases. So let's start with pediatric retinal diseases. So as we all know, children usually do not complain of any eye symptoms like blurring of vision. So parents or caregivers usually are the ones who notice any eye problems of their children. So, and the most common sign they note is that what we call leukocoria or white pupil. So it means there is no normal red reflex. So where's the white pupil or leukocoria here? Is it the right eye or left eye? So it's the white pupil or the leukocoria is the left eye. So this is the normal red reflex or normal ROR. So most common differentials for leukocoria, aside from of course cataract for children, would be these retinal diseases in children, such as HPP, Coats disease, retinoblastoma, and ROP. So these are the um, diseases that I want you to know. No? So in case you have children or patients, you'll become pediatricians, and you'll be examining your patients. You will note that there is a white pupil. So these are the differentials. So you have to refer them to an ophthalmologist. So let's begin with digging more on the embryology of the vitreous. So we will not able to tackle more about the embryology of the vitreous. So it can be divided into three: the primary vitreous, secondary vitreous, and tertiary vitreous. So as I discussed before, that the primitive lens and the vitreous is usually supplied by the hyaloid blood system or the hyaloid system. Your hyaloid artery, which is also a branch of an ophthalmic artery. It is considered to be the primary vitreous. So your hyaloid system is your primary vitreous. So it usually starts to develop at 7th week age of gestation. Then it should regress by 9th week until 3 months. No? So that is the time when the secondary vitreous also appears. Mga 9th week to 3 months, it fills up the posterior segment. So the green one would be your secondary vitreous. Primary vitreous, usually this one, the vessels, no? The hyaloid system, that is also the primitive blood supply of your lens. So this usually regress, no? And the secondary vitreous would then fill up the whole posterior segment. So at 4 months, the tertiary vitreous forms between the ciliary process here and the lens capsule. So a large number of collagen fibers develop with formation of zonular fibers. So your zonular fibers or your tertiary vitreous would become the vitreous base or your ciliary zonules. So that is the one that holding the lens, right? Your zonules. So ideally, the primary vitreous should regress. So therefore, in PHPV or your persistent hyperplastic primary vitreous, so this case, so this is the histologic picture of an eye, no? So it's persistent. So it is a failure of the hyaloid vascular system to regress. So therefore, there's persistent hyaloid artery and vascular membrane behind the lens. So it is usually unilateral in 90% of patients, and it's usually seen in term infant. So aside from leukocoria or white pupil, the patients would have small eye or microphthalmia, and shallow anterior chamber is also noted. So this is the band that I'm telling you. So connecting from the nerve up to the posterior lens capsule. So parang may band connecting the posterior and the anterior segment. So that's your PHPV. So usually it's poor prognosis. No, sometimes they do surgery depending on how extended the band is. So, but this is very vascular. So it's usually it's really poor visual prognosis for the children. Second differential would be Coats disease. It's another differential for leukocoria. It is a chronic, progressive, telangiectatic neovascular retinal disease of unknown etiology. So these are the abnormal vessels, telangiectasias. So as you can see, there is massive exudation under the retina. That these abnormal vessels would usually leak fluid and can lead to what type of retinal detachment. So later on, I will discuss more about retinal detachment. So Coats disease usually progresses. Once it leaks fluid, it could lead to exudative retinal detachment. So this disease is more common in young boys. Take note, less than 7 years old. And like PHPV, it is also unilateral. So these boys would sometimes exhibit blurring of vision on the affected eye, and the mother will note leukocoria or white pupil due to this extensive yellow-white exudative patch beneath the telangiectatic vessels in the retina that will negate the normal ROR in the fundus. So usual treatment for this, we do laser depending on how extend the telangiectatic vessels, or we do cryotherapy. So, but sometimes it's poor visual prognosis for these children. So very important differential again, so is ROP or retinopathy of prematurity. You will have leukocoria once there is already retinal detachment for the latter stage or for the late stage of ROP. So ROP is a retinal disease of preterm infants. So remember that the retina starts to become vascularized at 4 months. So take note, at 4 months, so usually the vascularization is like this. And at 7 to 8 months, usually the nasal retina is vascularized first before the temporal. And by 9 to 10 months, by term, the temporal retina is completely vascularized. So usually nasal retina is vascularized first before the temporal retina. So when we do screening later on, it's very important to that we see the peripheral retina. So aside from prematurity, other risk factors. So remember, we will stick to this, less than 32 weeks age of gestation, prematurity, and also low birth weights, having less than 1.5 grams, overuse of oxygen, excessive oxygen use, and unstable clinical course. So what are the unstable clinical course that we're talking about? If the patient had sepsis, multiple blood transfusions, so this would contribute to high risk of having ROP or retinopathy of prematurity. So of course, the more premature the baby is, expect that the more premature the retina is. So because at 4 months, ganito lang, vascularized retina. So the whole vascular retina is ischemic. So this is a very detailed pathophysiology of ROP. So, but I find it more simpler, this table. So if the baby is born prematurely, the more premature the baby, the more area of the retina will be unvascularized. So at the ICU, normally the baby will be hooked to oxygen. So therefore, there is an increased exposure of oxygen that will eventually cause vasoconstriction in the retina, resulting to vasoobliteration or involution of vessels. as the retina thinks that there is enough oxygen. So, and the retina will stop forming vessels. So therefore, the peripheral retina will remain ischemic, and this will signal the production of, very important to note, the VEGF, or vascular endothelial growth factor. So VEGF will cause or will result the following retina findings: tortuosity of the vessels, we term that plus disease. It can form neovascularization and iris vessel dilatation, or iris rubeosis, or abnormal vessels on the iris. So ROP may further worsen once there will be fibrovascular proliferation and retinal detachment. So very important to note that ROP is a preventable blinding disease. So these are the stages of ROP. No? So very easy to remember. Stage 1, there is a thin line or thin flat line between the avascular and avascular retina, vascular and avascular retina. Stage 2, if there is already demarcation line with more ridge or thickened enough. So this one, thin flat line. This one, maybe a ridge, medyo elevated. Stage 3, usually that's the time that we usually do treatment, especially if it's on the more posterior or zone 1 or involving the macula. So basta stage 3, there is already fibrovascular proliferation that is already extending on the vitreous from the ridge. Stage 4 and 5, usually there is already detachment. So stage 4, partial detachment. Stage 5, total retinal detachment. So in this case, 4 and 5, that's the time you would see leukocoria or white pupil in children. So this one, stage 1, line. Stage 2, ridge. Stage 3, fibrovascular proliferation. There's somewhat extension onto the vitreous already. And this one, yes, there's detachment. So this could be stage 4. Stage 5, total retinal detachment already. So aside from this staging, we also note, so if, for example, we see a baby stage 1, stage 2, stage 3, we note if there is plus or no plus disease. So plus disease, this is a picture of plus disease. As you can notice, there is increased venous dilatation and arteriolar tortuosity of the posterior retinal vessels. There could also be iris vessels engorgement. You can see that on the anterior segment. The pupil will not dilate because of these abnormal vessels, or there could also be vitreous haze, or there is already vitreous hemorrhage because of this hemorrhage, pre-retinal hemorrhages. So just like what I said, aside from staging the ROP, we also note if there is plus disease or none. So presence of plus disease in ROP would usually signify severe ROP progression. So since ROP is a preventable blinding disease, screening, very important, should be done as soon as the risk factors are present, and pediatricians should refer them immediately to ophthalmologists. So how do we do the screening? So we usually use an indirect ophthalmoscope, not the direct ophthalmoscope, the indirect ophthalmoscope. That is binocular, the one that it's different from the direct ophthalmoscope because in indirect, it's more wide field. So we can see the whole retina more, just like which is very important in ROP because you want to look at the peripheral retina. So you have to use the indirect ophthalmoscope. When you become clerk, you would see some ophthalmologists who will be rotating or will be at the ICU or NICU. They are screening yung mga preterm, mga premature babies. So you will see our setup. So indirect ophthalmoscope plus a non-contact lens. We usually dilate the eye of the baby. What the usual dilating drops that we use would be phenylephrine and tropicamide. So we You ask permission to pediatrician if you can dilate, or if the baby is stable. So because dilating drops usually can cause mild systemic side effects, so very important to ask permission sa pediatrician. So that's how we do screening. So, and again, the best way to prevent ROP is still prevention from premature birth. So this is usually the setup. So this is what I'm taught that as telling you a while ago, the indirect binocular ophthalmoscope. She's holding a contact lens there, not a non-contact lens. Then we see like this. So this is the treatment here. This is a laser treatment. So we treat ROP based on, or depending on the stage or the severity of the stage. So we usually start treating them once it becomes stage 3. So especially if it's affecting the posterior pole, or what we call the zone 1 or the macula. So ROP stage 3 is usually treated. 4 and 5 usually surgical na sila. So stage 3, so we put a confluent laser on the avascular retina, dun sa ischemic retina. So these are lasers, confluent laser. So this is the laser after maybe 2 weeks, so it will scar. So the peripheral retina is usually scarred. So we want to preserve, no? So unlike here na tortuous yung vessels, this time it's more regular. No hemorrhages already. There's no ridge or fibro stage 3. It's not elevated. So this is already a regressed ROP. So you are able to quiet down the ROP of this baby. So side effects, or usually when you laser the baby later on, they become myopic. So these are the things that we should watch out after doing laser treatment. Strabismus, or error of refraction, particularly myopia. So after doing treatment, after maybe 1 to 2 years or 1 year, usually do refraction. So especially in laser treated eyes. However, aside from doing laser, another because of advent of injections nowadays, so there is also intravitreal injection of anti-VEGF. So it's not VEGF, it's anti-VEGF. So you don't want the vascular endothelial growth factor, no, in most of our retina diseases. So later on, you will know more about injections. So we do intravitreal anti-VEGF injection also for aggressive type of ROP, and stage 3 involving the posterior pole. So after injecting them, or after injecting anti-VEGF, you do serial fundus exam until the retina would be fully vascularized at the periphery. Worst case, no, of ROP like stage 4 and 5, when there is already detachment of the retina, we do surgery, or the pars plana vitrectomy. So this vitrectomy is like a laparoscopy. It's a 3-port. You put a trocar on the eye. So you fix the detachment. So there's usually surgery. Actually, stage 4 and 5, it's usually hard. No? It's usually, the visual prognosis is already guarded. So that's why ROP is really a blinding disease. So it's important to do treatment as early as possible when it is needed. Or first, refer once it's preterm or with other risk factors, refer them immediately. And then for us ophthalmologists, we have to catch them. We have to do treatment as much, especially if it's worsening. So, especially in stage 3, so we don't want progression of ROP like stage 4 and stage 5, because it's usually poor prognosis. Next, another differential for leukocoria is retinoblastoma. So it is the most very important to know that it is a malignant. It's the most common primary intraocular malignant tumor of childhood. In 1 in 1 is to 14,000 to 1 is to 28,000 of live births are usually affected. Boys and girls are equally affected, no? Unlike in quotes, usually boys. So RB equally male and female affected. So it is usually unilateral, but can be bilateral in 30 to 40% of cases. And around 90% of cases, usually less than 3 years old. And it is usually caused by the mutation of the RB1 tumor suppressor gene on the long arm of the chromosome 13q40. So both copies of the RB1 gene must be mutated, so it can be hereditary in 45% of cases, most common sporadic in 95% of all RB or chromosoma. So the tumor would appear pale pink or white mass with vessels on the retina. So usually intraocular lang sila. And on ultrasound, there is, we take note of calcification. So we can see calcifications on ultrasound or on CT scan. So you can also request CT scan if it's, you're not sure if it's retinoblastoma. So, but clinically, you can say if it's retinoblastoma, but we sometimes, especially if the whole mass is on the whole retina, we can do B-scan ultrasound to characterize the mass. So we look for calcifications there. So when the tumor progresses, no, initially intraocular lang siya, it can become extraocular. So this is the white pupil, and there is already periorbital swelling. So like in this picture, so this is already extraocular retinoblastoma. So it's a malignant tumor, so very important to do treatment. No? It is a life-threatening condition. So treatment should be initiated immediately once diagnosed. And usually enucleation is done. So we remove the eye. No? We remove the whole eyeball, and it is crucial to remove also the optic nerve as well, so as not to leave the remaining tumor. So chemotherapy and radiation can be done pre-operatively to shrink the tumor before doing enucleation, or post-operatively to treat residual tumor. So we usually co-manage the patient or the baby with pedia-oncologist. So they are the one who give the chemotherapy for these children. Because sometimes if there's residual tumor, it can recur. So, and if this is, it's really life-threatening. So it's hard to explain to parents. No? So here in the province, I see a lot of RB. So I refer them to orbit specialists. No? They remove the the eyeball. But usual treatment for retinoblastoma is enucleation. You have to catch them early because, again, it is life-threatening. So let's proceed now to adult retinal diseases. So this time, adult individuals can easily complain anything about their vision, unlike children. So the following symptoms usually gives you a hint. No, these symptoms will give you a hint that it can be due to a retinal disease. So flashes, flashes of light or photopsia if there is traction in the retina because of you have photoreceptors, diba, in the retina. Floaters if you have any opacities on the vitreous. It could either be deposits, yung mga asteroid hyalosis, or it could be hemorrhage, or it could be merely vitreous. So maybe some of you will have complaints of seeing floaters, or white spots in their vision. So these are your vitreous that is already detaching, or they are liquefying on your eye. So it's a benign condition. So usually floaters are would signify retina disease or is a retina symptom. Scotoma and metamorphopsia if there is pathology affecting the macula. So on your quiz kanina, may tanong ako about the symptoms na retina that would, what are the symptoms of the patient that would really direct you to a retina disease? What's your answer there? Parang ano ba yung tanong, sudden, gradual, flash, ano ba blurring of vision with floaters. Ano yung mga tanong ko? So sudden with floaters. So usually baka later on you will note that that's usually a symptom of maybe retinal detachment. So di ba kasi ang blurring of vision usually could be either a cornea disease, lens opacity, no? So but pag may floaters, usually and sudden, maybe a retina problem siya. Sudden blurring of vision with floaters, maybe a posterior segment pathology. So we will discuss the common retinal diseases, this in each category. So let's start. So vaso-occlusive diseases, you have your central, your BR, central and branch retinal vein occlusion, or central and branch retinal artery occlusion. So these are strokes, no? So there's also a stroke in the eye. So because there are vessels and it's smaller than the vessels of your whole body. So CRVO is caused by the following mechanisms. So usually the patient would complain of sudden, painless loss of vision or blurring of vision. So the three mechanisms, the eye could be either due to external compression of the vein here, venous stasis, or degenerative disease of the venous endothelium. So usually there is a blockage on the near the optic nerve head or the central retinal vein on the optic nerve head or your lamina cribrosa. So the following are the risk factors for CRVO. Very important to note, this is hypertension, diabetes, cardiovascular disease, and the open type of glaucoma. So primary open angle glaucoma. And in young children, young individuals who experience CRVO, so in young CRVO, you would investigate contraceptive use, hypercoagulable states or mga blood disorders, and vasculitis. So however, pag elderly, usually hypertensive, diabetic, cardiovascular disease. So this is a classic fundus findings of CRVO. There's blurred optic nerve or blurred disc margin with tortuous vessels, dilated tortuous vessels, and with multiple flame-shaped hemorrhages on all quadrants. So this is not a picture of diabetic retinopathy. So usually nga to mga flame-shaped hemorrhages all over, all part of the retina, even the periphery. This is usually a CRVO. Very classic finding. So here you see also cotton wool spots. These are exudates, but particularly soft exudates, cotton wool spots. So there are two types of CRVO, the non-ischemic and ischemic. So in non-ischemic CRVO, the vision is usually good. So usually mga vision nila is usually 20/70 to 20/200. So unlike in ischemic CRVO, they usually present with poor visual acuity. So usually mga counting fingers to hand movements, no? And usually there is optic nerve swelling in ischemic CRVO so therefore there is RAPD, relative apparent pupillary defect. So there is severe or massive hemorrhages all over. So this is a fluoresceint angiogram of a CRVO. So mga block, these dark spots would be the hemorrhages. And after some time, this is an ischemic type of retina. You can no longer see hyperfluorescent areas. So these are capillary dropouts. So these are areas of non-perfusions, very extensive. This is an ischemic type. So these are laser eye. So these are the laser treated eye. So it's usually the treatment for ischemic type of CRPO because as we so very important. No, so it must ischemic CRBO has higher chance of more complications, particularly neovascularizations. So in general, CRBO, once you had CRBO, the patient would have blurred vision because of these following complications. No, could either be there could be macular edema, there could be the risk of retinal neovascularization or iris neovascularization is high in ischemic type of CRBO after 3 to 5 months from the onset of symptoms. So, but once you know that it's an ischemic type of CRBO, they could have this type, more neovascularization, more chance of having neovascularization because of ischemia. It's same pathophysiology with ROP because you have an ischemic or avascular retina. It will produce vascular endothelial growth factor. So it would have neovascularizations later on. So that's the common pathophysiology we have in retina. So in many retina diseases. So here also in ischemic type of CRBO, once there is ischemia, there will be increase in VEGF or vascular endothelial growth factor. So you would have neovascularizations. These are neovascularizations, abnormal vessels that can easily rupture. So if once there is iris neovascularization, this can grow also on your trabecular meshwork. So your fluid or your aqueous humor cannot drain. No? It's usually drained through your trabecular meshwork. So that's why in these cases, once there is neovascularization already in the anterior segment, there is a high chance of having neovascular type of glaucoma. Okay, so remember that. So particularly on the ischemic type of CRBO. But still, you have to follow these patients, either it's ischemic or non-ischemic. So CRBO macular edema may resolve spontaneously, or if it's minimal, yeah, you can just observe. However, in severe macular edema, you can do injection of before they do steroids, but we all know that steroids can have a lot of side effects, can have high chance of having cataract. You have chance or risk of having increased intraocular pressure. So these are the things that usually a side effect of intravitreal steroids. So like I told you, there are a lot of it's anti-VEGF in as a treatment in most of retina diseases. So we have intravitreal anti-VEGF for treatment of of the macular edema in CRVO. Once there is presence of neovascularization, you do laser. So this is what I'm telling you a while ago. We do laser on the ischemic part of the retina. So that the stimulus for having VEGF will no longer be present. So there would be no formation of neovascularization. So we do laser on the ischemic peripheral retina. So unlike CRVO, in BRVO, it's only half, no? The hemorrhages or intraretinal hemorrhage. What type of hemorrhage is this? What type of hemorrhages are these? What type of hemorrhage is this? So it's usually confined on half of the retina or half of the macula. It would either be superior or inferior half of the retina. What type of hemorrhage is this? Anyone? So these are plane-shaped hemorrhages. No? So the most common type of BRBO would be involving the superior half of the retina because according to studies, there are more AV crossings here. So many anterior venous crossings on the superior half of the retina. So in BRVO, there is occlusion on the AV crossing. So like CRVO, the arterial disease is called, or the BRVO disease, risk factors would be hypertension, cardiovascular disease, and increased body mass index. So if it happened in a young patient, you should investigate more in hypercoagulable states, OCP use, and so on. So, pero usually pag BRVO, usually patients are hypertensive with high cholesterol. So these are the things that you have to investigate also. Treatment, again, there is macular edema. You can either observe them or you can do injection. We do intravitreal anti-VEGF injection monthly. Before, they do macular laser on the macula for non-resolving macular edema. But nowadays, there is um, good outcome for injection. So as much as possible, we don't want to laser the macula because as we know, laser, there's scarring already. So we want to preserve the retina, especially the macula. So we don't, as much as possible, we don't want to do laser. So that's the beauty of injections or intravitreal anti-VEGF injection. So aside from doing this treatments on the eye, it's important to tell the patient to control their systemic disease, their hypertension, diabetes, so that you would prevent strokes or vaso-occlusive disease on the other eye. So usually, very important to note, vaso-occlusive diseases, BRVO, CRVO, CRAO, and BRAO are usually unilateral. So usually, classic finding patient would note of sudden blurring of vision on one eye. Next would be CRAO, or your central retinal artery occlusion. Classic symptoms would be sudden, again, painless blurring of vision on one eye. So there's what we call amaurosis fugax, which can precede, it's an antecedent transient visual loss up to counting fingers to light perception in 90% cases. The pathogenesis for CRAO could either be coming from an embolus, thrombosis, or vasospasm on your central retinal artery. So there is cherry red spot. So this is what we call the cherry red spot. As you can see, there is opacity of the whole retina or superficial part of the retina. Because that's the central retinal artery would supply the inner or outer, the superficial part of the neurosensory retina. So your fovea or your cherry red spot is preserved. The normal appearance of the fovea is preserved because it has different blood supply compared to the whole retina. So the opacification of the superficial retina would be due to infarction and reduced blood flow on the central retinal artery. And that's why also that becomes your fovea will become very evident because of also the opacification. But of course, because of different blood supply of your fovea. BRAO, or branch retinal artery occlusion, again, it involves there is whitening of the inferior or superior half of the retina. So here, there is whitening or opacification of the superior half of the retina. It is usually due to an embolic disease. Not only opacification, you can also see cotton wool spots or some hemorrhages. So, but mainly, basta opacification like this, CRAO or PRAO. Pag may hemorrhages, massive hemorrhages, it could either be CRVO or BRV. Just take note if it's involving the whole retina or half of the retina. Treatment for both CRAO and BRAO, systemic treatment, it's usually irreversible. If it's more than 90 minutes, it's already irreversible. So it's very important to catch them early. So it's, as you will know, CRAO is one of true ophthalmic emergency. You can do paracentesis or anterior chamber paracentesis to remove a small amount of fluid on the anterior chamber for as much as, so that we're hoping to dislodge the embolus or thrombus in the arteries. Or we give acetazolamide, it's a IOP lowering drug. We do carbogen mixture, or you tell the patient to inhale in a brown bag because it induces vasodilation and increases oxygen at the retinal surface. Or you can refer them to internists, they can give thrombolytic therapy. So, but it's this one, no, CRAO and BRAO, it's usually, you have to catch them early. The golden rule would be 90 minutes, so less than 90 minutes. After that, it will be irreversible. Now, let's go to the most common retina diseases, the retinal vascular diseases, the diabetic retinopathy and hypertensive retinopathy. Risk factors for having diabetic retinopathy would be long-term of having elevated blood sugar, chronic hyperglycemia, hypertension, hypercholesterolemia, and smoking. So in type 1 diabetics, no, they usually do not develop retinopathy for at least 3 to 5 years once it was diagnosed. However, in type 2 diabetes, may have retinopathy already at the time of diagnosis. So you have to refer, or you have to do ophthalmology consult at the time of diagnosis already. So this is a blood vessel. Take note of this structure, the pericyte, which is a supporting structure of your endothelium for endothelial cells. So this is the pathogenesis of diabetic retinopathy. Because of hyperglycemia, there would be loss of these pericytes, intramural pericytes, which are your supporting structures, which can cause later on thickening of the basement membrane. Therefore, your vessels would become incompetent. So there could be leakage or occlusion in these cases. So that's the main pathophysiology of diabetic retinopathy. There is occlusion and leakage of the vessels. So this is a more pathophysiology of the diabetic retinopathy. There is endothelial cell damage, capillary basement thickening. There is increase in blood viscosity or plasma viscosity, deformation of your RBC, increase in the stickiness of the platelets. This would cause decrease in the blood flow in the capillaries. There would be hypoxia or decrease in oxygen. So again, ischemia. Ischemia would cause, is a stimulus for a vascular endothelial growth factor. So once there is increased VEGF, there will be neovascularization or fibrovascular proliferation or membrane formation. So this is more detailed view of diabetic mellitus. No? So aside it from affecting the eye, retinopathy, it's a microangiopathy, ang retinopathy. So it affects the small vessels, just like affecting your nerves, neuropathy, or nephropathy. So retinopathy or the eye symptoms or eye complications would be under microangiopathy. So we should do early detection and treatment is very important in diabetic retinopathy. For type 1, you do screening within 3 years from diagnosis. In type 2 diabetes, we do it on diagnosis and we do annual or every 6 months after screening. We can do fundus photography or sometimes we can do angiography, fluorescein angiography. So, and especially you have to know that once the patient is got pregnant or that there's pregnancy at first trimester, you have to do screening. So sometimes obstetricians would refer them, once there's gestational diabetes or once a diabetic patient becomes pregnant, you have to screen it at first trimester or at least every 3 months until delivery. Because as we all know, once you get pregnant, there is increase, your hormones is increased, everything is increased. So there is higher chance of diabetic retinopathy in these cases. So there are two types of diabetic retinopathy, your non-proliferative and your proliferative diabetic retinopathy. So under non-proliferative diabetic retinopathy, there is three, your mild, moderate, and severe. In mild diabetic retinopathy, there is only presence of microaneurysm. So in the fundus, you can see only red dots, small hemorrhages, red dots. On moderate type of diabetic retinopathy, aside from microaneurysms, there is already your hemorrhages. It could be either be intraretinal hemorrhages like your blood hemorrhages or flame-shaped hemorrhages. Venous bleeding or like a segmentation or on the veins or cotton wool spots. So basta there's these findings, there is the diabetic retinopathy is already moderate. However, in severe, we have the 4-to-1 rule, meaning in 4 quadrants, there is intraretinal hemorrhages, around more than 20 intraretinal hemorrhages. In 2 quadrants, there could be venous bleeding. In 1 quadrant, there is IRMA. So IRMA is like this. So it's similar to disorganized blood vessel or capillary. So it's a shunt from your artery and vein. So that's the 4-to-1 rule is already severe. So again, microaneurysms only seen as red dots. That's mild. Moderate, if there is, aside from microaneurysms, there's hemorrhages, bleeding, and cotton wool spots, automatically moderate. Severe, it should be many. The 4-to-1 rule. So 4 quadrants, 2 quadrants, 1 quadrant of these retinal findings or retinal signs. So this picture is not that clear. So red dots, these are microaneurysms. Moderate, there is cotton wool spots here. Severe, so many intraretinal hemorrhages, multiple. So proliferative, on the other hand, you already have neovascularizations. You already have abnormal vessels on the nerve and on peripheral retina. So these are abnormal vessels or neovascularizations. They are florid. So this, once you see this one, it's the pre-retinal hemorrhages or this meniscus or boat-shaped type of hemorrhages. These are pre-retinal. It's already proliferative. It could either be early or high risk proliferative diabetic retinopathy. Early, pag mga neovascularizations lang. On the disc and on the elsewhere on the peripheral retina. High risk if there is already vitreous hemorrhage. Neovascularization of the disc at more than 1/3 of this diameter. So we measure any lesions on the retina based on the disc. So this is more than 1/3. If the neovascularization elsewhere is more than half of this diameter with vitreous hemorrhage, it's also high risk. Very important to know na basta may hemorrhage na siya, it's already a high risk type of diabetic retinopathy. And if there's already membranes plus neovascularizations, it's already considered to be proliferative. Proliferative diabetic retinopathy, other complications of diabetic retinopathy, the deformation of membranes, the fibrovascular membranes. So these fibrovascular membranes would pull your retina, causing traction. Later on, producing retinal detachment. So tractional retinal detachment in severe cases of proliferative type of diabetic retinopathy. So aside from diabetic retinopathy, there is also what we call diabetic maculopathy. So meaning could either be edema on the macula or ischemia, ischemic. So this is a fluorescein angiogram. So this is a fovea, the foveal vascular zone. It should be round. So this one is already irregular. So there is ischemia already. So edema, what happens when there is breakdown of the inner blood retinal barrier. So what is your inner retinal blood barrier? What are your inner blood retinal barrier would be your inner. So your retinal blood vessels or your endothelial cells. Pag outer blood retinal barrier, that's your RPE. So ang affected sa diabetic retinopathy would be your inner blood retinal barrier. So when there is disruption of this one, your inner blood retinal barrier, there would be leakage of fluid and plasma surrounding the retina. So this is your macular edema. It could either be focal or diffuse. Ischemia, this is a type of ischemia. So this two type of condition would cause blurring of vision. This one could be cause permanent vision. So because if ischemia, we don't do laser here on the macula, so we can't do anything about it. Yeah, it's usually chronic cases of diabetic retinopathy could lead to very ischemic retina. So they can also proceed or result to neovascular type of glaucoma. So pero mas common ang neovascular glaucoma in mga CRVO. So these are pictures of diabetic retinopathy. So this one is a membrane, traction bands of diabetic retinopathy. These are pre-retinal hemorrhages or the boat-shaped hemorrhages. So this, once you see this, it's already automatic PDR. This one just NPDR. So basta may neovascularizations and membranes, traction membranes on the retina, automatic proliferative diabetic retinopathy na yung diagnosis niya. So the diagnostic test that we can request would be OCT. So we told you already, in OCT you could see the layers of the retina. So this is a picture of macular edema. You would see separation of the layers, particularly your outer plexiform layer. So may mga cystoid spaces or hyporeflective cystoid spaces in between the retina. So we do injection here until this would flatten. So we can request OCT to monitor the macular edema. FA or fluorescein angiography. So this one, you can see multiple hyperfluorescent dots, so very florid. This would be leakages, so usually neovascularizations usually leaks. So kapag PDR, you can see your leakages in the retina. So this is ischemic part area of the retina. So you can request for fluorescein angiography to check for the microvascular or retinal circulation and to check for non-perfusion. Treatment, very important, that I always tell my patient is to have a good control of not only your blood sugar, but also your blood pressure and your lipid profile or your cholesterol. So always tell the patient. And then we do laser in cases of proliferative type of diabetic retinopathy. So you see this is already a lasered eye. You can do injection for macular edema, anti-VEGF, and vitrectomy. Also, so we can also give triamcinolone or steroids for macular edema. But just like what I told you, because of advent of VEGF, intravitreal anti-VEGF, we do most of the time an injection of anti-VEGF for macular edema. Vitrectomy once there is already membranes and vitreous hemorrhage. So in worst case, common procedure or surgical procedure we do in retina would be vitrectomy. So this one. Especially in non-clearing vitreous hemorrhage and traction membrane. So, but again, very important to tell the patient to have good systemic control. Next would be hypertensive retinopathy. So, risk factors for having hypertensive retinopathy would be duration, long duration of your hypertension, severity of your dyslipidemia, elderly patient, and of course, if you are smoking. So it affects your precapillary arterioles and capillaries, which is an anatomical structure for autoregulation and non-perfusion in the retina. So if you have uncontrolled blood pressure, there could lead to non-perfusion at different retinal levels. So these are the staging that we do in hypertensive retinopathy. So stage 1, if there is arteriolar narrowing, so normal ratio of artery to vein is what? What's the normal ratio of of artery to vein in a normal fundus? Ano? So normal would be 2:3. So normal artery to vein ratio is 2:3. So kapag hypertensive, ibig sabihin narrowed yung artery, so that's 1:3. So mas narrowed yung arteries. Grade 2, aside from narrowing, there is focal irregularities or may nicking, artery and vein nicking. Grade 3, there is already hemorrhages and exudates, hard exudates or cotton wool spots. Grade 4, if there is disc swelling or nerve edema. So again, treatment, systemic control. Usually kapag hypertensive retinopathy, we do systemic control. We don't do laser. Then if there's macular edema, we can do injection. It can be reversible. So there are 3 types. So next would be, we'll talk about the detachment. So common you would hear in retina or retina disease would be detachments. We have 3 types of retinal detachment, your rhegmatogenous, traction, and serous, or hemorrhagic, or exudative. So pare-pares lang, serous, hemorrhagic or exudative retinal detachment. So let's discuss one by one. So pag regmatogenous retinal detachment, so there is regma. The word regma means thickness. There's full thickness break on the retina, on the sensory retina, maybe due to a traction. Therefore, the liquefied vitreous would go into the retinal hole or into the subretinal space. So, di ba, embryologically, there is really a space, or the ventricle, there is really a space between the neurosensory retina and the RPE. Because embryology, there would be the cupping, the inner wall and the outer wall of the cup. So that's, I told you before, no? There's a space between the inner and outer cup, your optic ventricle. Kaya there is a potential of retinal detachment. So it's usually preceded by posterior vitreous detachment. So usually aging. Trauma can cause regmatogenous retinal detachment also. Myopia, so if you have a long eye or nearsighted, long eyeball, you have thinner peripheral retina, so you are prone to having breaks. So usually mga Chinese, mga Singaporeans, so usually they have, as you will note, they have thick eyeglasses, so usually they are nearsighted. So they usually are the ones having floaters. So it's important to do fundus exam to them to check for any potential holes. So this one, no, they do, we laser the retina if there's no detachment already. But usually if there's retinal detachment, we do surgery already. So important, we do to find the retinal breaks, we laser the break during surgery. So there are different types of holes or tears. The horseshoe tears, which is usually common in supertemporal quadrant of the retina. Atrophic holes on the temporal quadrant. Retinal dialysis is usually larger holes on the inferotemporal quadrant. So very important to note that regmatogenous retinal detachment is caused by, usually preceded by your PVD or posterior vitreous detachment. So this one, no, we all know that your posterior segment or at the back of your eye, the vitreous is filling the posterior segment of the eye. And this vitreous is attached on your retina, on your nerve, on your optic nerve, temporal vessels, and the fovea, and very adherent on the vitreous base. So what type of vitreous is in here? Primary, secondary, or tertiary vitreous, embryologically. What type of vitreous is now present on the adult eye? Primary, secondary, or tertiary? Here, this one. Vitreous dito. What type of vitreous is that? Ano? What type of vitreous? Diba I discussed a while ago the different vitreous embryologically, kung saan sila nanggaling. Primary, secondary, tertiary. So this one, what's the one that is already present on the back of your eyes, that what is that? Primary, secondary, or tertiary? Anyone? So yeah, so it's a secondary vitreous. So, di ba? Because the primary regress. So usually regress. Yung primary vitreous mo is the vessel or yung hyaloid system from the nerve to the lens. So usually nga, di ba, nagre-regress siya. So, ang natitira is your secondary vitreous. So, once the primary vitreous regress, secondary vitreous would fill up your whole posterior segment. Ang tertiary vitreous would be your zonules and your vitreous base. So going back to retinal detachment, so your vitreous is adherently usually sa retina, sa parts of the retina. So when you age or when you myopes, mga nearsighted, it liquefies. So sometimes it causes traction. Kaya sometimes it pulls part of the retina, so it can form holes or tears. So this would lead to fluid coming into the subretinal space, so causing retinal detachment. So that's how retinal detachment occurs. So next type of retinal detachment, you have tractional retinal detachment. So classic disease, or where do you find what's the most common disease that you find tractional retinal detachment? So you see membranes here on the retina. It can pull or cause traction to the retina. It can proceed to detachment. So what common eye disease that you know that would cause tractional retinal detachment that we already discussed? Ano? Diabetic retinopathy. So particularly proliferative type of diabetic retinopathy. So it can produce membranes, and once it produces membranes, it can pull the retina and it can cause elevation of the retina. It can sometimes cause tears. So other disease would be ROP, you can see also traction retinal detachment. Trauma can also proceed to traction membranes. So it has a more concave surface, more localized. So depende sa where the membranes are seen. And it's usually not extending to the ora serrata or onto the periphery, unlike in retinal detachment or in regmatogenous detachment. So usually nga pag regma, usually sa peripheral retina ang may mga tears. However, sa tractions, usually on the posterior. So here, on the macula, peripheral, not so periphery. Kaya nga it's not extending on the ora serratum. However, in serous retinal detachment, you don't see any break, you don't see any traction. So parang the retina is just elevated. So this is usually caused by, if you have a disease on the RPE, your end choroid. So in serous retinal detachment, there is compromise of your inner or outer retinal blood barrier. So in serous retinal detachment, or we call exudative type of retinal detachment, there is a compromise of your inner or outer blood retinal barrier. Ano? So ang pag-inner retinal blood barrier, usually sa mga retinal vessels or sa mga endothelial cells, particularly compromised in diabetic retinopathy. In serous RD, nakasulat na dito, it's a disease of your RPE and choroid. So usually, the outer retinal barrier is compromised here. So usually we see this in posterior uveitis, inflammatory or infectious or degenerative diseases. So take note, in serous, there is no break, no traction. Next, so very important to note that lattice degeneration, no? It's a peripheral degeneration. So we see this on the peripheral part of the retina. So it may predispose detachment or retinal detachment because these are thin areas of the retina. It can produce holes. So just like what I said, it's common in myopic eyes, mga nearsighted, those with thick eyeglasses. It could be due to there are linear areas of retinal thinning with pigmentation. There is firm vitreoretinal adhesions at its margins, so really it can cause traction. No? When there's posterior vitreous detachment, it can cause traction or holes here. So it can predispose to retinal detachment in 20 to 30% of cases. So what type of retinal detachment when you can happen if you have lattice degeneration? Where I would have would predispose to what type of retinal detachment? Diba there are 3 types of retinal detachment. So kapag may lattice degeneration ka, what type of retinal detachment do you think would happen? Would predispose your eye? Ano? What type of retinal detachment if you have lattice degeneration? Rhegmatogenous, tractional, ano? So it's usually rhegmatogenous. So rhegmatogenous, you can have tears or holes. Tractional, it's due to traction. So usually mga diabetic retinopathy or OP. So pag this one, lattice degeneration, there is staining on the retina. So it can cause rhegmatogenous or retinal holes. So treatment for this one, if the patient is asymptomatic with floaters, flashes of light, so any traction causing in the retina can cause flashes of light. Symptomatic individuals with lattice degeneration, we can do laser, prophylactic laser. So we put laser, barricade laser around the lesion. Retinoschisis, no? Unlike in retinal detachment, wherein there is separation of your neurosensory layer and your RPE, this time in retinoschisis, the break or the separation would be within the neurosensory layers. There's splitting of retinal layers. So in there are 2 types. The degenerative retinoschisis would have, it's a common acquired peripheral retinal disorder. So it develops from coalescence of peripheral cystoid degeneration, common in imperotemporal part of the retina than your superotemporal. So there are 2 types of the degenerative type of retinoschisis. They're typical and reticular. In typical, the layer that is split is on the outer plexiform layer. However, in reticular, so it's more anterior, it's on the nerve fiber layer. Okay? So next, we have a few more. Hopefully we can finish. Macular hole. So for macular hole, it's a full thickness loss of tissue here on your fovea. You will see there as a red dot on the macula. It is due to a traction, tangential traction of your vitreous cortex. So usually elderly patient would complain of blurring of vision. So what do you think would be the symptom of this patient with macular hole? What would they, what type or what eye symptom would they usually complain? Did I discuss the signs and symptoms? What symptoms? So there is blurring of vision. Aside from blur, what you will ask them to describe their blurring of vision. So I told you a while ago, once it's affecting the macula or central vision, usually there is scotoma or metamorphopsia. So anything involving the macula, usually the symptoms would be scotoma or metamorphopsia. So this is an OCT picture of a macular hole. You could see a complete loss of the foveal tissue here. So this is a normal picture of the macula. So this is a complete. In macular hole, there is a defect here. So treatment is we usually do healing. We peel the membrane here that is causing traction. So it's again surgical. The treatment is surgery, vitrectomy. Another disease in the macula would be epiretinal membrane. So here, there is membrane here. No hemorrhages, there's tortuosity. So it's not a diabetic retinopathy. There's just a formation of membrane result due to proliferation of your fibrous astrocytes, fibrocytes, and RPE cells. So on the retina, you would see a wrinkling of the retina and distortion of these vessels. So here is the OCT. You would see here the membrane. So the smoothness of the anterior surface of the retina is gone. So again, can be due to systemic disease, idiopathic, aging, uveitis or infection can lead to formation of membrane. So again, what do you think would this patient or complained of? So what will their symptoms be if you have membranes on the macula? What membrane? What will they complain? There's membrane on the macula. So there's still blurring of vision. What else? So there is the membrane is mismo on the macula. So again, there is metamorphopsia. So distortion of the vision on the central, not diplopia. I already discussed the symptoms in the retina. Diplopia is not one of them. Another common disease, retinal disease involving the macula would be your CSR or your central serous chorioretinopathy. So there is a fluid or elevation at the center of the macula. There's a fluid underneath. Usual risk factors would be young males with type A personality, usually medical student, doctors, lawyers, usually professionals they could have chronic use of steroids, stress. They can have CSR. So usually the patient would complain of sudden blurring of vision on the central part of his vision. So there is a scotoma. So on OCT, you will see a fluid underneath. And on FA angiogram, there is leakage. So there is hyperpermeability of your choroidal vessels, altering the pumping action of the RPE. So as we all know, RPE is very important in maintaining the dehydrated state of the retina. So and also for the vitamin metabolism, the changing of the nutrients in the retina. So RPE is a very important structure. So once it is compromised, so meaning that you have compromised outer blood retinal barrier, there could be CSRs. So treatment, there is usually spontaneous resorption. We also usually observe, but chronically, if it's more than 1 to 3 months, we can do laser on the leaking vessels. Macular edema. So we've discussed this already in diabetic. Macular edema could also be present in vaso-occlusive disease like your CRVO and BRVO. So it could there's fluid accumulation on what layer of the retina? On your outer plexiform and inner nuclear. So this is a diabetic type of macular edema, usually with exudates. So you can also have macular edema after cataract surgery. We call that Irvin gas syndrome. Treatment could either give steroids or NSAIDs or intravitreal triamcinolone. But common, again, is intravitreal anti-VEGF. That's a common treatment for macular edema. But first, you should know where the macular edema is coming from. So it could be due to inflammatory causes, diseases, vascular diseases, we've discussed it, membranes, epimacular membranes, intraocular surgery, retinal degeneration, drugs intake, or idiopathic. Eales disease is a complication, usually extrapulmonary type or infection of your TB. It's a non-specific peripheral periphlebitis, no? Usually young men or adults with peripheral neovascularizations. And the peripheral retina, etiology is unknown. No? It's usually T-cell mediated vascular hypersensitivity. So Eales disease is usually caused by a hypersensitivity to tuberculoprotein or particular TB. So important to work up the patient for TB. Again, usually the patients would usually have vitreous hemorrhage, young men with vitreous who would complain of sudden blurring of vision with vitreous hemorrhage. So common affecting the young men. RP is a peripheral degeneration or a hereditary degeneration. It's a progressive dysfunction of photoreceptors. There's atrophy of retinal layers. So usually the blurring of vision of RP would be progressive. So the triad that you would note, the signs would be attenuation of the retinal vessels, tail retina, and this one, the bony spicules, or these are pigments from your RPE. So it's a generalized photoreceptor disorder. Particularly rods are affected than your cones. Symptoms, I discussed before, once it is affecting the peripheral retina, it would cause nyctalopia or night blindness. It would have gradual progressive peripheral visual loss. So an ERG or electroretinogram, there is markedly reduced. Aside from seeing a fundus like this, there could be cataract, cystoid macular edema, and membrane, so that these are the things that you can treat in this kind of disease, because RP is a hereditary, it's a congenital, you can't do anything about RP. There are usual treatment, you can give vitamins, particularly vitamin A, to hasten the progression of blurring of vision. So, but very important to know the classic triad, signs and symptoms of retinitis pigmentosa. So we'll continue the half of few more slides or few more disease in retina, so it would be short, so we'll stop here. And I'll give your long exam next week, so that not many would have 0. So I'll coordinate with your president for the long exam next week. I posted a case discussion there and on the Google Classroom, and it would be the last submission would be on Sunday, I think. Okay. So any more questions? Your attendance would serve. Your quiz would serve as your attendance. Okay.
Thank you po.
Okay. Thank you.